Good evening, one and all. Welcome to webinar Yashoda Hospitals group. I'm Dr. Vinith Ilapuram. I'm working as Emergency Department Head, Secunderabad branch. So today we are here to talk about POCUS. So we have one of the eminent speakers with us to talk on this international faculty, and I'll just debrief about him. He's none other than Dr. Jim Connolly. He is consultant in NHS UK, and he's a acting president as of now, EUSEM, European Society of Emergency Medicine, and he is past chair for ultrasound section EUSEM as well as the RCEM US ultrasound workshop. And he is the first person to start the ultrasonography course point of care test, this thing at UK in 2001, as well as he is the author for 2 books related to ultrasonography in emergency department. So I ask him to further go ahead. Over to you, sir. You can start the class.
Thank you very much, Vinith, and thank you, everybody, for the kind invite. Firstly, can I say I hope you're warmer than I am here. I'm in the UK and it is freezing. It is really cold. I hope in the next 30, 40 minutes to be very controversial. I want to make you think about what is happening out there. So sorry, sorry. I'm screen sharing. Sorry, my apologies. My slides are not moving. Okay, so thank you all. Thank you, Srinath and Vinith, particularly, and for Yashoda Hospitals and the Society for Emergency Medicine for hosting this meeting. I always think before you listen to anybody, you should ask, do they really represent an expert? And I don't know if you have any definitions in India, but in the UK, we think anybody who comes from out of town with slides, they're an expert, okay? Unfortunately, I'm sat at home, so that doesn't apply. But I like the Danish physicist Niels Bohr's definition, which is that pick a very small area, make every mistake you can, and then talk to people. So that's what I'm hoping to do in the next 30 minutes. And I'm hoping to make you think about how you practice medicine, about how you view point of care ultrasound, and really what the vision for the future is. I have a couple of quick declarations. I get occasional money from a company, and I have some machines placed in my personal care. And I'm a zealot. So sometimes when you listen, you have to recognize I'm probably a very extreme person when it comes to ultrasound. So you may want to moderate my thoughts. I wouldn't say I was obsessed, but my staff call this machine Mrs. Connolly. Okay, I spend so much time. And in fact, we take it on nights out as well. I work in a busy, probably not as busy as Hyderabad, but in a very busy major trauma level 1 center, seeing every patient possible. But I live in a part of the world where, please visit me. It's right on the edge of where the Romans stopped, in a historic place called Hadrian's Wall. And people think the Romans stopped here because it was too hostile on this side of the border. The reality is they stopped because the weather was so bad, they could not grow grapes and make wine. So they said, this is enough. This is the outer empire that we will stop at. So please come and visit me. So I'm going to talk first of all about my POCUS journey, why I took on ultrasound. And that's just important because in many ways, the history dictates how we use ultrasound and how we will use it in the future. I'm going to challenge you to think differently about how you examine patients, how you assess patients. And then if you're not already there, I'm going to really encourage you to join the revolution that's happening. This started really with what I consider the worst words in ED. We've always done it that way. Okay, that's a classic thing and it stops progress. And this is me in almost 2000 down in Cambridge. And at this point, I thought within a couple of years, it would be absolutely widespread. It has taken much longer than that. And I may explore some of the reasons why POCUS has taken slightly longer to take off than we'd hoped for initially. Because one of the things that holds us back is this. Okay, my talk is about certainty. It's about certainty of diagnosis, certainty that what we're doing is good. But I hazard and I warn you that certainty is not always evident and is not always evidenced by the reality of what's out there in the educational literature and the medical literature. So in some ways, certainty is a feeling, not a fact. But that's still important when it comes to patients. Okay, the feeling you have can actually be quite critical. This is really, in the end, a revolution. It's saying This is 200 years old, okay? Sticking something on somebody's chest, currently with a bit of rubber tubing and something that vibrates. This is considered the standard, okay? But it's 200 years old. It's crazy that we even contemplate that this is accurate enough or good enough. But I also hazard to say physical exam in its current state is also really to be challenged, okay? What do we actually do when we tap on somebody's chest? How accurate is it? And all of those things we need to be honest and actually appraise and say, is this valuable? Is it adding anything? Okay. I'm not knocking the stethoscope, by the way. I still have a lot of uses for my stethoscope. Okay. Place to hang things if I need them, scare children, if somebody's hard of hearing, and if I've run out of a straw to drink my beer. There are still lots of uses. I am joking, by the way. Stethoscope still has a value, but we have to accept it has a limited value and is not as good as we think. Okay. So my POCUS journey begins. And we really realized at the beginning that we were up against the radiologist, but we should never have been. This was never a problem. Okay. Because we initially got this wrong. We thought this was all about speeding up radiology. Okay. We'd go around and ask for an aortic ultrasound. No, you're not having one. And all of these cases that we all have. So that's where we thought. And we thought it would stop us and make us self-proficient. And we also knew that it might help us to get patients there quicker. Okay. Particularly fast scanning, which was the initial investigation of choice and would help us to get people to theatre quicker. And that was proven to be a value and proven that it would happen. But time passed, and time passes always quicker than we'd like. And we began to realize, whoa, 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 this is not radiology. This is actually nothing really to do with radiology. We still work with radiology on it, but actually we needed, and we slowly recognized that this is a dynamic adjunct to your physical exam. It is increasing your certainty or decreasing your certainty. When you think you know what's going on, it's about applying something that either makes it more likely or less likely. And we're doing that repetitively. We may not know we're doing it, but that's what we're doing. And that's where point of care and certainty come together. Okay. Increasing the certainty, increasing your certainty, even though it may never be 100%, pushing you as close as possible to that position. So now we have this revolution. Sound now is now represented electronically, not as a sort of in your ears, and the potentials are huge if we consider it in the way I'm saying. If we consider this is about making your diagnostic skills better. One of my colleagues always talks about making very bad doctors better, okay, as a source of ultrasound. So we now have this very powerful tool that can help us with that. And where are we? This is a standard chart of any medical investigation or anything that comes out of medicine. You have the initial crazy people, the sort of people like me in ultrasound who just are so enthusiastic, okay? And then people join late, okay? The most sensible people join around here. And I actually think genuinely we are at this point. I think we've got most sensible people on board. And in fact, there's a massive clamor for educational skills and to be taught this, to take it on. There'll always be some people who never take it on, but I think we're truly at this point and this tipping point. Okay. Let's go back on my journey. Trauma was where it all began. Okay. Trauma is massive. I know it's massive in India. It's massive even throughout the sort of European world as well. It's still the biggest killer of under 35-year-olds in our part of the world. Okay. And accidents will always happen. We will never be out of a job. Okay. We will never not be working. Sorry, I just got rid of something there and it didn't help. Okay. ATLS. Just want you to ponder for a second. There is no doubt ATLS revolutionized how we handled trauma, what happened in trauma. Okay. You know the story. And the figures are breathtaking. Over 1 million people have gone through ATLS courses. This is staggering. Okay. But again, I just go back to the certainty element of how certain are we what we're doing is good. Okay. We put in fast scanning, and fast scanning is slowly accepted, and it's taken quite a long period. There's still people who say it's rubbish. You shouldn't be doing it. And I'll explain why those people have some traction, but I'll also explain why that's not a great concept. Okay. So in many ways, I come as that Roman soldier on the wall. I'm not coming to bury ATLS. but I am going to mention some of the shortcomings and then talk again about certainty. Okay. So I am going to praise ATLS still because ATLS has done a huge amount of good. It has revolutionized our skill set, our ability to do things, our team working. But what's interesting, this is not knocking ATLS, there is no objective in Cochrane review of evidence base. The evidence base does not exist for it improving survival. This is often a criticism of point-of-care ultrasound. You've not shown the evidence, but let's just stop a minute. One of the most accepted educational tools has not been shown to increase survival. We know it does, by the way. We just know it does, okay? And that's, again, my certainty element, okay? Certainty is a feeling, not a fact, that the evidential base may take decades, if not longer, to gather, but it will gather, okay? And this is the same as point-of-care ultrasound. ATLS, promo again, promotes teamwork, provides an incredible structure, teaches life-saving skills, and makes things happen quickly. It is massively beneficial. We know that. So again, take me from what I'm saying. I'm not knocking ATLS, okay? But there are problems. And my problem comes a little bit in accepting that trauma is not just one disease. There's massive variation in skill set, in availability, lots of things. And it tends to use that one responder. But more importantly for me, I think it uses some outdated skill sets in terms of assessment, okay? It almost becomes ritualistic that we stick a stethoscope on, that we tap a chest, that we listen for muffled heart sounds, okay? In my research room, you would never hear muffled heart sounds, okay? Everything's muffled. It's so noisy, okay? You want a primary survey to be fast, accurate, and make every action matter, okay? That's what we want from a primary survey, okay? And the bottom line, okay, CT we know gets you there, okay? It is much quicker, but use your head. It's not always available. Sometimes you're overwhelmed. So still being able to assess patients is important, okay? So physical exam versus POCUS. Here's the killer paper. I'm going to deliberately leave this on. I'm more than happy to send this talk to anybody who wants it, by the way. But if you ever need evidence of its effectiveness and its ability to be more accurate, okay, that medical students sent with 2 days training on how to look at a heart, pathology, valve pathology, pitted against board-certified cardiologists. I deliberately don't label which one's which, but you get my idea. Who was better? Who was more accurate at finding physical issues with the heart? Those using a point-of-care ultrasound or those who've trained for decades and years, okay? So think through the process. You go and see a patient. You already in your head have an idea of what you think is happening. Oh, I think that looks like an abdominal pain. Oh, they look very pale. I think they're bleeding. Oh, they're very sweaty. There's something going on cardiac-wise here. You have in your brain a perceived view. And then you apply questions. Is the chest pain in your left arm or your right arm? Interestingly, by the way, right arm is more important than left, if you didn't know. Okay. Is it crushing? Is it central? Is it in your back? A test. Do we do an X-ray? Should we do a blood test? All of these things keep adding in, okay, to make you more or less likely. And to this, at the bottom, we're going to add POCUS. Can POCUS help you? If you want to read a bit deeper in this, I cannot recommend this book highly enough. Okay, I have no reasons to do this, but an ACEP book, David Simmel, about what actually happens and how good are the tests and the questions that you do. Okay, if you don't recognize this individual, this is Bayes, Thomas Bayes, who is a mathematician or was a mathematician and created the whole Bayesian thinking that we're talking about. Okay. Do you make things more likely or less likely as you apply a test? Don't want to go into statistics too massively, but only two numbers to remember. Making it more likely, a positive likelihood of 10 is a really good test. Okay. Trying to make it less likely, 0.1 or less is a good way to make it less likely. Now, probably worth quickly explaining, that doesn't mean it's 10 times more likely or 10 times less likely. Okay. It generally means you're 45% from where you were. Okay. So if you're really bored, by the way, you can take any paper you like, And if you know sensitivity and specificity, you can work out your likelihood ratios, okay? It's just an easy way to do it. You can, again, find this online. So without going too crazy here, let's think about this. What I'm really saying is you go up to a patient and you're 50-50. You're equally balanced. It's heart failure. No, it's a chest infection. You're equally balanced, okay? And then you apply a really good test to make it more likely, likelihood ratio of 10. After that test, you're up into 95% certainty. But you're not just doing one test, of course. On top of that, you'll listen, you'll hear crackles, you'll find a third heart sound. All of these things will keep pushing you in that direction. In terms of excluding or saying it's not this, you go to the chest, okay? You do a test that has a really good test, and you're into much lower percentages of that being the reality. So that's what you do all day, every day in medicine. And POCUS, I'm going to show in the next 5 minutes, can truly change the way you assess patients, okay? So again, imagine you're 10% sure, you have a real good excluder test, you're down to the tiny percentages. You're 90% sure of something, you put an excluder and actually it pushes you away from it. Doesn't take it away, but it makes it much less likely. So that's what you're doing and want to do all the time with ultrasound. A pause, okay? This is just talking about heart failure. And this may stagger you. So this is a patient with heart failure, and I'm asking the question of which of these signs, tests, so JVP, crackles, is the best? And it's interesting, triple heart rhythm, okay, is the best test to make it more likely. Interesting, okay? And ruling it out by not hearing things in the chest is not that good a test, okay? None of them are 0.1 or less. Whereas ultrasound, and for those who are used to ultrasound, you'll know this, but this is lung, there's ribs, and this is the surface of the lung with the white shadows coming down, okay? Or B lines. Here again, some more B lines. These are the sign that this lung is wet. And look at this. Wow. Okay. If you see 3 of these in bilateral, must be on both sides, okay, in 2 zones, okay, your likelihood ratio is 12. Much more powerful than anything you looked at on physical exam. Whereas ruling it out, okay, incredible. If the lungs are dry, the lungs are dry. They're not failure. So it's a fantastic rule out test, okay? It's how good it is, okay? Incredibly good. If you are 50-50 and you see no wetness, okay, you're suddenly into this realms of it being highly unlikely, okay? If you are 50-50 and you see the B lines, because it's about 12, you're into the high certainties, okay? And again, you can keep going like this, okay? That presence of the B lines tells you whether the lungs are wet or not. And I think that's a brilliant example. But I'm now going to hone it and just talk about lots of other areas of medicine where you may practice this. And particularly, I'm going to talk about the primary survey, which is the beginning point of all of this, okay? First of all, primary survey, we don't use it enough, is incredibly good at detecting tracheal intubation, actually placing it over the trachea, okay, passing the tube. And if you pass it down the esophagus, you'll see it. Go Google, just Google intubation, ultrasound, and just see what you find, okay? It's incredibly easy to do. You normally see a trachea, but if you happen to intubate the esophagus, you get 2, and it's much quicker than anything clinically you'll do. But let me show you a few other things, okay? Pneumothorax is the be-all and end-all, I think, of a trauma resuscitation. Those who are used to this, okay, there's the sliding. Okay, that's the pleural sliding. This tells you that this lung is moving, okay? This lung is not moving, okay? And if you want to make it more accurate, stick your M mode process probe down, watch what happens at M mode, and you get this. It's the same all the way up, okay? You don't get the classic seashore sign. You get this barcode or stratosphere sign, okay? You don't get the M mode sign, okay? You will occasionally, if you're lucky, see a point, okay? And at this point here, there is sliding here, see? But there's none here. So this is the edge of the lung, which is an even more certain test. If you see this, almost by definition, almost 100%, has to be pneumothorax, okay? That's the point that we're seeing there. okay? And again, you see these comet tails coming down from the surface, okay? A lot of studies out there saying 2 views, 4 views, in effect, couple of views, most anterior if you're laid on your back is probably good enough. And these are the figures. They're incredible. I'm sorry if the video is in the way there, okay? But incredibly sort of positive likelihood ratios are incredible compared to any other test. What about fluid? And this is my favorite, okay? In a trauma, seeing people do this left and right. Really? Okay. That's just not good enough. Okay. The accuracy of that is terrible. And we know that. Okay. This is more a study on pleural effusions. Okay. There are a lot of sort of signs here. Okay. But in general, asymmetry, okay, is a good sign. Okay. But most of the other sides, particularly dullness, are not great. Okay. The likelihood ratios are just not good enough. Okay. But look at this. If you see fluid, 47. Wow, that's just phenomenal. Okay, in terms of, yes, there will be fluid. But even more importantly, if you don't see fluid and if you're good enough at the test, you exclude it. This is much more accurate than any tapping on the chest will ever be. Okay, and then onto my favorite, pericardial. Here's a liver, a heart swimming in fluid, and you can see there that heart is in trouble. That right ventricle is in trouble. Okay, and this is really saying that, okay, classically, we look for Beck's triad. Okay. Apologies for that very poor dad joke there. Okay. But you're looking for that muffled heart sounds, low blood pressure. Okay. Really in a rhesus room? No, not going to happen. Okay. Quick bit of what I like to call dogmalysis. Okay. This is Cliff Reed from Australia talks about this. This is stuff that's grown up for years that we just accept as truth. Fluid is black. Fluid isn't always black. So one of my words of caution here is there occasionally, this is big clot. There's only a little bit of fluid. So I am being very positive about ultrasound, but we also need to recognize there are shortfalls as well. So this fluid is gray. It's clotted blood. It's very different. Okay. Back to abdominal trauma. Now I'm just going to pause again and let you catch up a bit. The real thing we want here is a great test to say, we know they are bleeding. That's what we've always been after. Physical exam, fast scanning, okay? And this is interesting. Remember our figures of +10 or 0.1 or less. Seeing a big seatbelt sign pushes you and says, be careful here, okay? Rebound, moderately good. Not saying it's no good. Low blood pressure, moderately good. Of course, if you add these together, they don't just add to 11, but adding them together, rebound, low blood pressure, guarding, they all start to make it more likely, okay? This is the worry, and this is why FAST developed a bad reputation for a while. Okay, sorry, but no tenderness. Let's come back to FAST reputation in a second. No tenderness does not exclude bleeding. So a soft belly does not exclude bleeding. It's not a good enough test, okay? Other things that are useful, base excess of less than -6 is a good predictor. Interesting. One of the better predictors, okay? But the others are not so good. But wow, look at this. And again, my apologies if it's hidden by the, okay? The general positive likelihood ratio is really good, but the negative likelihood ratio is not 0.1 or less. From memory, it's 0.6, so it's been hidden by my videos here, okay? It's not good enough to exclude, okay? Whew. Sudden explosion. We now know FAST is great for looking for fluid, for finding pleural fluid, abdominal fluid. It's much better than physical stuff that we can ever do, okay? So this now opens up a whole new world. This is the whole new world of certainty. We suddenly have an explosion. And I'm going to go through now the explosion of stuff that's happened. So I'm going to rapid fire through some likelihood ratios, some other bits of exam, but there are multiple ones out there, okay? What about ascites? Our favorite ascites, do you remember from medical school? Shifting dullness, okay? Tap the belly, okay, roll them over. Oh, dear, dear. Okay, that's not a great test. Okay, 2 likelihood ratio. Okay, here's an interesting one. If you haven't got ankle swelling, 0.1 is a good excluder, negative. If you haven't got ankle swelling, you're probably not likely to have ascites. Okay, that the abdominal swelling is probably not going to be ascites. Okay, so all of these again just show you that you're not getting brilliant results from physical exam. okay? We mentioned those earlier. They're considered the better ones, but really not that good, okay? What about signs? This is interesting. Cholecystitis, okay? Clinical gestalt. We talked about the certainty before, and certainty is a feeling, okay? Actually thinking it's gallstones is as good as anything else we've got, okay? Murphy's is not so good, tenderness and right upper quadrant, okay? And certainly negative or not having a Murphy's or tenderness doesn't exclude cholecystitis, okay? Whereas, okay, really looking for stones, thickening of the wall, or fluid, or sonographic Murphy's, okay, really push you into good, positive, and negative likelihood ratios. So again, seeing a stone, and thank you to Sono Atlas for these images, which are freely available. You can see the stone, okay? That ups your ante, okay? Seeing pericholecystic fluid or thickened gallbladder, all much more accurate tests than prodding and listening over the abdomen, okay? What about being pregnant? It's an interesting one, okay? Patient thinks they are, has a reasonable likelihood ratio, but not brilliant, okay? Various other tests help. Seeing the baby, and I'm indebted to Chris Fox for that one, just to lighten the mood and wake you up for a second, okay? But seeing a baby, or probably as important in the world we live in, not seeing a fetus in the sort of sac and in the uterus are critical tests, okay? So uterine stripe, but no obvious sort of signs of fetal movement, okay? Here's a bladder and a uterus with a sac within the uterus, reassuring that this patient's issues are not those related to an ectopic, versus, again, a sac here away from the stripe, away from the uterus. Incredibly valuable test, much more accurate than physical exam. Aortic screening, again, quite a lot of aortas will not be palpable, aortic aneurysms, in patients with horribly low blood pressure, okay? Whereas we know that in patients with horrible blood pressures, that ultrasound is better, okay? And I hope you can see the figures here, that actual seeing an aorta is much better, an aortic aneurysm, than physical exams. And I hope you can see those. If not, I'm again more than happy to send this talk as a talk so you can actually see these figures, okay? One of the things that haunts us a lot in the UK at the moment is aortic dissection, okay? And the ability to detect it. And again, you can see a lot of the signs and symptoms we look for. Tearing pain can be a good one, okay? Certainly in terms of excluding it, pulse deficit, blood pressure difference, x-ray, no tearing pain, don't quite make the mark, okay? Neither does diastolic murmur. But actually opting people in, 2 or 3 of those together really ups your likelihood ratio, okay? And we know that, and we can adapt that. From a point of view of ultrasound, seeing a massive aortic root, okay? And that's the aorta. So that's left atrium, ventricle, that's the aortic root there. And if you see that, that really is a strong indicator that the pain you're having could be a dissection, okay? I'll throw a few more quick ones away. Optic stuff, so much better than ophthalmoscope, okay? You actually see, this retinal detachment, okay? And my main reason d'etre, okay, the reason I took an ultrasound, back to my POCUS journey, was not about the subtlety of picking up muscle tears. It was about handling very sick patients. So the last 5 minutes, I just want to angle into this. The whole ethos of point of care ultrasound is sick patient, getting there quicker, getting the diagnosis quicker, okay? It is incredibly sensitive, okay, at picking up fluid loss. So here's a flat IVC, very flat, okay, compared to a normal IVC, okay? A normal IVC collapses by about a third, but just be careful because, of course, the IVC moves a little bit as you're breathing. So just be a bit careful sometimes about overreading this, okay? Incredibly accurate. And then my favorite, cardiac arrest.
They beep everyone. First doctor in has to run the room, tell everyone what to do.
So this is the serious scrubs, and you realize, oh, maybe I don't really know, and maybe I should let somebody else get there quicker. Okay, I'm not advocating this, by the way, but there is luckily the very cool Turk who has been around for a long time, and he's good. Okay, Turk's good, but here's my point. cardiac arrest management is fundamentally flawed. Let me again just be controversial. Cardiac arrest management is fundamentally flawed. Why? Because it relies on a pulse check. Okay. How good are we at pulse checks? We're not. Okay. The whole of the ELS algorithm has pulse check, pulse check, pulse check. How good? That's how good we are. Flip a coin. They've got a pulse. Oh, great. They've not got a pulse. Oh, okay. We are that bad. And we know that from evidence of taking medical people into a theatre, people with a low blood pressure, and actually we're really bad at detecting if it's there or not. And if we force people to do it under 10 seconds, they're even worse. You might as well flip a coin. So the evidential base, and I'll keep going about this, that we're running cardiac arrest on pulse check needs to be challenged as a physical exam because we don't know which of these is the reality. We don't know whether it's a horrible LAD. We don't know if it's tamponade. We don't know if the heart is barely beating just by feeling for a pulse, which we may or may not detect, okay? We don't know. This heart is beating absolutely crazily, but the right ventricle is massive, okay? Flattened septum. We don't know that's what's going on, okay? And we need to know. And I'm thankful for Michael Blavas for showing this one. You'll occasionally even see VF if you look. This is VF. It's not a still heart, okay? This is, again, was not detectable on the monitors. So again, just that whole diagnostics. And aware of where I am in this talk, I'm just going to quickly whip through some cardiac stuff and then call it a day. But one of the problems with ultrasound and cardiac arrest, it hasn't been promoted further by ILCOR yet, okay? But this is our problem. This is not ILCOR's problem. ILCOR is a very international liaison committee, very scientifically driven process. And we have not produced the evidence to show, okay? And there is still doubt whether it's of value. You and I probably know it is, but there's still not the evidential base to say it helps, okay? Part of the problem here is our research base has not labeled the same thing, okay? We've actually not even established a proper dictionary of how we refer to cardiac arrest, how we describe findings, and that's critical if we're going to get the evidence base, okay? What we do know, grade 1 evidence from, this was from WindFocus, okay? It's much better at detecting a pulse. We know that, okay? And that's well evidenced, okay? You and I know, and the evidence is gathering, 1B, it gets you there quicker, okay? There's a few problems though, okay? We think it's good for prognostication, but it's a nice bit of work from Brett Nelson. If you take the same video slip and show it to a whole load of people, they have a different view of what's truly still and what's not. So we have some variation in our thinking about what's still or not, okay? So although this is useful, okay, predicting whether people will survive, okay, it doesn't totally get there. So one of the things we very much highlight at the moment is that it does help your thinking a bit, but it should not be the only excluder to continued CPR. My favorite at the moment, just be careful, for a while, we got very obsessed saying a dilated RV, right ventricle, equals thromboembolus. Not always. And in fact, one of the common things, nice study on pigs, most right ventricles dilate up during CPR. So it has to go with the story and it has to fit in. Just a dilated RV on its own is not necessarily the answer. So caution, my last 2 minutes or so, it can negatively impact. We need to be honest about this, okay? When you let people loose with ultrasound, they almost double their time, okay, of pulse checks from 8 seconds to 13 seconds. But that's part of our problem about not doing this correctly, okay? Doing it correctly means you have to be in position.
Stop massage.
Stop, beep, capture a video, back off. So the answer to this is to get in position and capture a short 2-3 second video. And that way you can minimize and even lessen pulse rest, okay, or pulse check times, okay? So final word, and then I will hold it, mindful of if you want any questions and whether I've been too controversial, okay? There is an issue with some of the research around this, that guess what? If we see people have still hearts, there's a nice bit of book from Paul Atkinson, we stop. So this is all the studies. We stop quicker. We don't intubate. We give less adrenaline. So actually, it's interesting. It's a self-fulfilling prophecy. So although we probably know this and we probably know the outcome, we've got to be careful that, again, our certainty or our uncertainty doesn't push us to do things and actually change the outcome. Okay. But here we go again. There is no evidence of benefit of POCUS in cardiac arrest. Agree, there isn't. But again, we're in good company. Okay. Certainty is a feeling, not always a fact. Okay. I'm going to leave you with this last one and then I will hold it. Okay. The future. This is a bit of work from Philippe Turan in the States. Transesophageal probe down, showing what happens during cardiac arrest. And what's happening is this patient is having the aortic outflow tract compressed. Good position, normal position, but what we're not achieving here, we're actually deliberately, if you see up here, this is the aortic root. All we're doing is blocking the output, okay? And Philippe has done a lot of work on this because actually the position we think we're in is not always the position that you'd want to be in, okay? And a lot of work is going to go around individualizing. This, to me, is the future. Getting our CPR better, using ultrasound to guide it, okay? Spreading the skills. This is not going to be easy, but we need to train people more, and we need to accept it's not radiology, okay? One of the things I'm going to quickly talk about here is we recognized this has to come from within. And the big thing in the UK we did in the last couple of years, train lots more trainers so that actually this is done in the department by EM people, and the sign-off, okay, is local. We don't expect people to attend anywhere else, and it's like any other skill. We think that will really progress this rapidly so that it is like every other skill. It's not different. It's like every other skill. So my final words, I think AI is going to really push this. AI can already identify what we're looking at for us, okay? It can already steer the beams for us, okay? This is a nice little thing I've just seen recently saying back to our pulse check issue. We now have the ability, and this is a company in Norway, to place something on the neck, and that will tell you if they have a pulse rather than you using hands or even nearing to steer it. I.e., what I'm saying is point of care ultrasound will change and be made easier, and the acquisition will be made easier. So I know I've been hopefully controversial. I believe POCUS will disrupt medicine massively, especially the physical exam over the next few years. It will decrease our uncertainty or increase our certainty, and the AI and lower costs will further accelerate this development. So thank you very much. I've hopefully not bored you. I'm more than happy, as I say, to let you have copies of this talk. There's my Twitter handle and my email if you want to contact me. And then I'm sure you don't mind me plugging European Society meeting next year is in Copenhagen. Thank you very much.
Thank you, sir. Thanks for the wonderful talk. It was very beautiful and informative. It was more of pictures actually, and it was good actually. We'll go with the question sessions if there are any. I'll just have a look.
I hope there are. I deliberately was trying to be controversial to get people
Yeah,
fighting,
true.
excited. And again, I'm happy. I can clean this talk up a bit, and I see somebody asking for slides. So if you want, I can clean it up, remove anything that shouldn't, and then send it as a PDF to you. Would that be the best way?
Yeah, yeah.
More than happy to do so. And again, more than happy if anybody wants, you saw my email there. If you need anything, because I'm such a protagonist of ultrasound that if you
Sure.
say, hey, I'd quite like a talk on cardiac arrest, I'll happily send you one. It's not a problem.
Yeah. Sure, sure. There's a question actually. There's a bit controversial. That's what you spoke. Totally agree that uncertainty is there with the POCUS. Do you think there is poor research around POCUS? And if we were asking about the wrong questions, is the survival benefit the actual outcome we should measure in relationship to POCUS? It is being augmented physical examination. Also, finding the normal is sometimes one more steep narrowing towards abnormal.
Yeah, I love that last comment. And sorry, I've just seen I just saw there was a pop-up getting in the way of something. So my apologies for that. No, I'm a great believer in that. And the more we do this, just recognizing lack of normal is critical. So I love that comment that a lot of point of care ultrasound is I know what normal looks like. And even just looking and going, I don't know what it is, but that's not normal. It is critical in all of this. So rather than teaching people thousands of different pathologies, just recognizing normal, 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 oh, abnormal. okay, is where it's at.
Yeah. I'll check out if there are any more questions.
Okay.
Uh,
Just while you're doing that, I think the research is poor, but again, it's a difficult area. You're right. Survival benefit is difficult because, it can be proven, but it's going to take so long. And of course, one of the problems is it's become almost standard. It's when you're trying to study something and say, we're going to withdraw it. Having said that, there is experience of doing that in the UK. They've just done, I'm sure people have heard about the adrenaline study where but it got a lot of difficulty in terms of ethics, in terms of public perception, that during cardiac arrest out of hospital, some people were putting the adrenaline standard arm and some people put in the other, and it caused a lot of angst. Okay, but it's interesting, of course. I don't know if you know the results, but the results were that giving adrenaline got a better rate of ROSC. People survived a hospital, but their neurological outcome was terrible or was worse. So it was a good study to do, but I think it is up to us to get this evidence, but I think it will be a long process because of the variability in cardiac arrest and the difficulty even with Utstein. It's difficult.
there's one more question. I'm a viewer from London and NHS. How do you advocate POCUS training towards those who says we are always do it this way?
The only way is to do it and show them. It is because, of course, that was the early days. There was quite vociferous objection early days. It's from Gokul, from some people, and still even about 10 years ago, you would get comments like, why are you using the guessing stick and all this sort of stuff, but it's time in the end, and it's the slow build up of skills that most people who have that feeling, one day something happens and the light switches on. Okay. So one day, a case happens and then people are, oh yeah, actually we should be doing this. And it is interesting, the not the creep, but the expansion has been much more dramatic. And you'll see it. Almost every subspecialty now of medicine is taking it on. Acute medicine, ITU, 10 years, pediatrics. So almost every subsection is like, actually, we need to now get involved in this. It was EM, and I will always say this, EM in many ways that drove this, certainly in parts of the world where I've been involved in teaching it. And every other specialty is now saying, we need to get a hold of this and have it part of us.
Yeah. There's one more. POCUS has always been labeled with it as good as performing physician. Does that actually affect its accuracy? Is there any study comparing finding accuracy prior to training the current guidelines? Because even then, I think most people still pick up abnormalities on ultrasound better than physical examinations.
I love that question. Thank you very much for that. And it's critical. I mean, I've been quite simplistic in my, hey, these are the accuracies. Don't forget, because we're using their papers, so just pick aorta, for example. We're picking papers that were written 5, 10, 15 years ago by people like me who are a bit obsessed. So that the problem is that, yeah, that you're never going to be able to say the likelihood ratio is 4.2, because actually the reality is there'll be a big variation in people. And I know the most accurate people are going to be the ones who've been doing it for a while now. Those people, as we talked about, who really don't believe in it, are going to be slower to pick it up and probably less accurate. So there is going to be a range. We just have to accept that. But I think what we then have to do is put it up against whatever else we're dealing with. And the one I emphasized, I hope very strongly there, is pulse check. I cannot believe that this or this, feeling full, even after 10, 15 scans, I'd argue that, it's just common sense that being able to see a heart beating is much better than this. It's a common sense thing, really, which is, it's going to be difficult to prove outcomes, but certainly you can prove the Americans taking the echo into the clinic and getting medical students, and measuring accuracy. It is possible to measure accuracy of things in that regard. I mean, I think it will come into guidelines soon, but I think the reality is, I say, the guidelines are very evidence-based, which is what they should be, but doesn't mean that you shouldn't think differently. There is somebody asking about starting their journey on POCUS. Okay. I think there's a lot of great stuff out there now. There's a lot of great stuff online. POCUS Atlas I was showing you there. There's Sono, whatever. So there's Sono. 5 minutes Sono is good as well. But really, just get a feel for that, and then you really want to try and find somebody who will teach you hopefully some of the basics, because I think the stuff you need somebody standing over you for is to get the image and move the probe and just know that little bit. Now, in the sense of rurally isolated people, the companies are already recognizing that. So actually, there's a lot of work being done. I won't mention any specific companies on remote training, on being able to train people remotely, so that they can have a visual, a bit like us here, a sort of a visual webinar type thing, or even the machines are being designed in such a way that they can work out and visualize and tell you how to move the probe. So I think for those who are starting on the journey, I think there is stuff out there and equipment out there to help that. But otherwise, you just try and spend some time or even a short day with somebody who's been doing it for a while, who can focus you. Because one of the problems is you go to radiologist who'll be helpful, I'm sure, but they need to know what you want to know. They need to know what's important to you. And so I know early on during the echo sort of phase of developing POCUS, we had to go to them and say, we don't need to know that. We just need these things. So it took a while to work that one out. So radiologists will be incredibly helpful. And in fact, that may be the way in. Pick a specific skill and just get them to train you on a very specific. But it's almost like reversing it. It's almost like saying, what in your hospital, your region is the most pressing area? Okay, and that varies throughout the world. It's and even regionally, in my hospital there is a problem with this particular pathway. In my region there is a huge problem with DVT. In my region there's a huge problem with late pregnancies presenting. So it's almost like picking the skill set and the patients who most need this, and then being highly focused and recognizing that, how can I improve my examination of these people, my assessment? Okay. And really in that regard, it's, that's an individual thing. So I hope that's been helpful.
There's one more question. Is there any standardized position view that best for the using during CPR in cardiac arrest, and especially if locus is being used, as it makes positioning difficult?
Brilliant. Okay, absolutely brilliant. Yeah. So the generally most people go for this sub-xiphoid. Okay, and the reason being exactly what you've said, it's out of the way of the lucus, it's not interfering, you're not getting jelly all over the front of the chest. So most people go for that subcostal view, very specific, and it means that you can be in position during CPR. And I hope I know I included a lot in that talk, but I hope I included that really well, that the ideal scenario is to be in position, be massaging, and have the machine ready to capture 2-second, 3-second video, so that all you're interested in is and off, hit the video record, 1, 2, 3, beep, back on. So you can then go to the machine and just watch the video over and over again. So the idea being you can really get in there and out very quickly, 2 seconds, even 1 second, but 2 seconds would, of course, any beat below 30, above 30 would be picked up on a 2-second loop. So yeah, subcostal. And then there's a good IFEM document on shock and shock ultrasound and cardiac arrest, Paul Atkinson led, which then says you have to have a backup plan. And the backup plan is probably the parasternal long axis view here, that gets you, your second backup plan, because it's not always possible to see through the subcostal view.
Okay. Yeah, the questions are done, I guess.
Yeah, there's some nice
Guys,
comments.
any more questions, you can just please post. Anyways, I can see that your first slide was justified. Mrs. Jim. So it looks how passionate you are about ultrasound, sir.
And again, I am passionate, and if anybody just wants to email me, feel free. So
Yeah, sure.
yeah, so
I
there was a
don't
question
think there are
about,
any more.
somebody was asking during CPR, how can we see the plaques view? And again, you just have to do what I said. It's unfortunate. You have to just, Lucas is a problem, of course, but you just have to sort of say, okay, hands off, and then find the plaques view as best you can. And just that I think that paper was really valuable. It just said that because you have a new toy, be careful that you don't spend lots of time looking and you're not looking at the patient. So in many ways, I think whoever's scanning ideally should not be the team leader. And the team leader should be keeping an eye and saying 5 seconds, 8 seconds, get off, okay, back to CPR. Do you know what I mean? So it's important that, and I've seen it. It can happen. People get I can't find it. I need to. No. Okay, can we feel a pulse? We have to go back to the old-fashioned way of doing things sometimes. But okay,
There are no more questions actually. If there are any, we'll contact through mail.
yeah.
As you have posted your mail over there. Thanks for the beautiful talk, sir. It was very informative.
My pleasure, and I'm sorry that the Norton pop-up was advertising and may have hidden some of the figures, but again, more than happy to share that talk either if you email me or
We're very
I'll
happy
send
with it. And Srinath sir, do you want to give any?
Yeah. It's thank you, Jim. It was very nice and very wonderful. I know that you're busy and it's Christmas Eve, which is coming up in one day.
Yeah.
But still, you have accepted our invite and came here. On behalf of Society for Emergency Medicine India and also Yashoda Hospitals Group Management, I sincerely thank you for spending the time and being with us for this wonderful lesson. Merry Christmas and Happy New Year. Thank you all.
My pleasure, and again, thank you everybody for taking the time to listen, and I look forward to seeing you.
Great. Thanks a lot, sir. Happy and a Merry Christmas. Happy New Year too. Have a
Thank you
great
very
day.
much. Okay, take
Thanks
care.
a lot. See you, sir.